Got it.
Hi, everybody. Welcome to the July Health Equity Destination Health Equity meeting. Tiffany Go is our host today. And Tiffany, please go ahead.
Thank you so much, Sonali. Thank you. Thank you. Let me go ahead and then just double check. I'm getting an error on my end, and I will reshare my slides. Can everyone see my screen? Excellent. Okay. Thank you. Hi, everybody. Again, my name is Tiffany Go. My pronouns are she, her, hers, and I'm the Health Equity Program Manager at the Fred Hutch Cancer Center in Seattle, Washington. I actually live in Federal Way, Washington, which is south of Seattle, but I am a Washington State native. I actually grew up in Skagit County, and I'm actually a first-gen American, which makes this really, really fun. One thing I like to start off with for all of my presentations that I do outside of work is that I'm going to bring my whole self into this presentation. So that also includes some possible interruptions from my husband, because we also have a 4-month-old, and I just got back to work from maternity leave. So just want to be real and authentic with all of you, that my passion for health equity definitely exceeds the bounds of work. But I also have, like many of you, multiple identities outside of work, which is also a working mama. I just wanted to give a quick shout out to the health equity team, which technically was just me, but we had the privilege of hiring Beth Alaribe, who covered for me while I was on maternity leave. So it was such a pleasure and a privilege to have Beth as part of the team, covering for me for the last 5 months. Beth is a physician assistant by training and has been doing health equity work for the last 10 years. And I don't believe Beth is here tonight, but I just wanted to give credit where credit is due, that she kept the flame flying, so to speak, while I was out for 4 months. A little bit about me. Thank you, Sonali, for providing a brief bio. So I've been at the Fred Hutch Cancer Center Legacy Seattle Cancer Care Alliance for 7 years. I initially started as a financial counselor. I did that for about a year before transitioning to the patient experience team. Our patient experience is embedded within our quality management department, which also includes our patient safety department and division as well. So a lot of the work I did prior to managing the health equity program has been around navigating patient complaints through our patient relations department, looking at our patient satisfaction scores and comments that patients submit in our Press Ganey surveys, also with working with our PFACs, our Patient and Family Advisory Council, and our patient family advisors. So there was kind of this triad of work happening in patient experience, and I had the opportunity to work in all of that. Concurrently with that work, I've always had a passion for work around diversity, equity, inclusion, because as a woman of color, I have a lot of lived experiences in which that is really important to me. So passion is not really the right word. It's more like I have a charge in my life to ensure that my experience and the way that I'm experiencing the world is equitable and equal. And so I gravitated toward the DEI work at Legacy Seattle Cancer Care Alliance. And the reason why I bring that up is because it really put me in a advantageous position, I think, that transitioned me into this role into health equity. So my work is really at the intersection of patient experience and DEI and clinical care with a quality improvement lens. So there's kind of a lot happening for the health equity program. And then just my background overall is I've been in nonprofits for over 10 years and have worked in direct client services as well as program and coordination management, always in healthcare access and looking at outcomes. So it's a very different world working at a cancer center instead of a small nonprofit with 13 people where you're kind of doing all the work, and now being at a larger institution and actually getting some resources to get the work done. So yeah, that's a whole conversation in terms of resource equity, but it's just really interesting experience for me. So I'm going to provide a pretty light overview of the health equity program. The reason why it is light and it's more of an overview is I can do literally a deep dive on all the components of the program at large. But in the interest of time and really just to generate a conversation, this is a very introductory, high level about the health equity program. And I thought it was important actually to really start the story of our program and the overview on how we got here. And so how do you build a health equity program? And I really like this James the Scribe depiction of flying the plane while you're building it with the commentary that says we all have a piece. This was very much the feeling I had and many of us had when we started the health equity program. I have a timeline that I'll show you, but it's kind of flying by the seat of your pants and really just trying to figure out, is this what we want to do as a center, as a hospital for health equity initiatives? Happy to share that today that we are, the plane is flying. We have the direction. We're leaving off the tarmac and landing. And we really have the wheels turning. It doesn't mean that we're still not learning and figuring things out along the way, and really just trying to figure out our priorities and working with stakeholders and partners. But I'm happy to share that we're no longer building the plane, we are going. And we have a good sense of direction of where that is. So this is our commitment to health equity as an institution. I'm not going to read this for you here, but I will take a minute to pause to let you absorb and read this here yourselves. And one of the most important elements I really wanted to point out here is the idea of addressing not just institutional injustice, but also systemic injustice and racism in health and cancer care. This is a big core of what we do in the health equity program, and we can't do this alone. We all have a shared responsibility to address institutional and systemic racism and injustice in health and cancer care. So that's something that I really wanted to underscore in our commitment as an institution. So how did we get here? This is a really high level timeline. I did not get as granular as I would like because there would be a ton of text on the screen. But really what started our track, I believe, was the reckoning on race. And it really started with the murder of George Floyd. Shortly after that, that was around the Memorial Day weekend in 2020, King County Public Health declared racism as a public health crisis in King County, Washington. So that was huge to have that declaration by Dow Constantine, our executive. And I think that really set the tone and the bar for health institutions and cancer institutions in our area to say, what are we going to do with this information? What obligations do we have? Internally, there was a group that was led by my past director in quality to address and to measure healthcare disparities within, again, legacy Seattle cancer care. We had never done that. We'd never looked internally to say, are we actually providing equitable care to our patients? Are we doing that for access, for how soon patients get in to see us? What is the timing to their first appointment? And are we looking at that and stratifying that by, patient identifiers? So demographics, looking at gender, language, race, ethnicity, payer, geography. And the answer is no, we were not doing that. So that was kind of the first form of having a group of folks coming together who are passionate about health equity and addressing disparities, to really take a look inward to say, how are we doing? And Sonali was also part of that work in that work group. So Sonali can provide a little bit more context and details if you all have questions. So unsurprisingly, we found some statistically significant disparities because no institution is perfect in the way that we provide care. And those disparities were then presented to our executive leadership March of 2021. During this time, the quality department, again, that kind of took this charge, said, hey, we really want to dedicate some resource to health equity. We see this moving forward. And that's when I got promoted. So I was half-time doing health equity work, which was just forming, and then half-time still doing patient experience work, which was helping out with navigating complaints and really managing our patient and family advisor program, and then being pulled away from the Press Ganey work for patient satisfaction. We got executive leadership to support health equity as a strategic breakthrough priority, which was huge. So that happened in 2021, and our fiscal year begins in July. So starting in the fiscal year of July of 2021, I wanted to make sure that we were well positioned to have a group of folks support the initiatives going forward for health equity, which was forming our Health Equity Advisory Group. So some of the members from the Measuring Healthcare Disparities work group transitioned to this advisory group. And it was mainly so I wasn't just flying by the seat of my pants alone, that I was getting multiple perspectives from our SMEs, our subject matter experts across the organization, and partners to say, am I doing this right? Is this the direction in which we want to go? And is this the right way to tackle these particular problems? At the same time, the Washington State Hospital Association just began their Health Equity Collaborative. And that was a collaborative to invite hospitals across Washington State and actually Oregon to participate in a all teach, all learn collaborative with building health equity components. And if memory serves me correctly, OHSU was actually a participant, so that made it really, really fun. So the goal of as part of this collaborative was to lead 3 90-day quality improvement sprints or PDSA cycles within 3 different domains. And I'll talk a little bit about our involvement and participation in the Health Equity Collaborative. So starting in our new fiscal year, we had some goals that we wanted to tackle that were formally established at the organizational level. And I was pretty much tasked with, these are our goals. Go ahead and find some operational partners and let's meet these goals. Then I'll talk about those in detail as well. So several months later, just really trying to make sure that we were meeting those goals, again, wearing a QI, a quality improvement lens, and the problems that we wanted to tackle. And then I became full-time in this role about a year ago. So I was absolved of participating in some of the other patient experience work, and then just really trying to focus on health equity, just health equity. This also came about the idea of establishing a health equity collaborative. So actually that's incorrect. It's not June 2022. It's actually June and July 2023 that we just established our health equity collaborative. And then Sonali, I just learned that we got approval to hire an additional FTE to help me. So I won't be a team of 1 for the rest of my life. So I'm very excited that we'll be having an additional resource to help lead the charge for health equity. So how do we prioritize what we actually do within our institution for health equity? So I include these buckets here. This is the easiest way in my mind on how we kind of move forward. So really the National Institutes of Health, when it comes to what we report and what those guidelines are, especially for grant dollars, right, for research, have some requirements that we have to adhere to. So that was a big driver. And the biggest one of that was having accurate patient-reported demographic information. So that actually was the first starting point for us. The Joint Commission, which is a regulatory and accreditation body, also established some health equity standards. So that happened in 2022, and then those are live now, starting in 2023, in which we would actually be accountable for and audited to ensure that we are meeting those standards. Again, those disparities that were identified from the health equity analysis, the analyses that Sonali assisted with, that also drove some of our priorities. So I'll talk about our pain-related ED projects in a little bit. And then having those internal and external partnerships that also just came along the line. So the Health Equity Collaborative, and then later being part of a NCCN Health Equity Report Card study. And then just recently being part of an internal study to collect sexual orientation and gender identity for our patients within 3 sites. And then now that we've merged, Seattle Cancer Care Alliance and Fred Hutch became one organization last year, we also have a joint adult oncology program with the University of Washington Medicine. So that also kind of helps shape a little bit of our priorities of how we want to be more of a cohesive center. So we have a seamless experience between folks going to oncology care at UW and then oncology care at Fred Hutch as well. So starting with patient demographic collection, this is really the foundation of all of our work. If we do not have accurate data on our patients, we are not able to accurately identify disparities. And Sonali knows this firsthand because when we had done our initial analyses a couple of years ago, we had a pretty large unknown rate for our patient demographics. So I'm happy to share that we were at about an 82% completion rate for new patients coming into our center. And that was about June, I think, 2021. So we're at 91% completion rate, which is great. Change management is really hard. There are a lot of folks who do not want to ask our patients, what race do I identify? What ethnicity do you identify? Soon, we're going to be asking them to collect information about sexual orientation and gender identity, or SOGI, also an area of discomfort for some people. So it's taken a lot of partnership and change management, working with our clinical operations managers and then our frontline staff to really improve that collection rate. Our goal is 95%. It's been 95% for 3 years. We're at 91%, and I'm really getting to a point where I don't know how much manual work and behavior change we can do before we start to say, can we go ahead and introduce a tech option here in the medical record? More to come. I'm definitely trying to push towards automating some of our collection. It's just a way larger conversation to have, but I am still happy to see that we've improved our collection by quite a bit in the last couple of years. So this is more information about our participation in the Health Equity Collaborative. The reason why I really wanted to bring this up is those 3 domains that I have listed here on the left side of the screen. I wanted to use the opportunity to conduct our 90-day PDSA sprints around data collection because we did not have standards for collecting patient-reported demographics. It was a little all over the place, depending on what service line, depending on what clinic. Some were really great of having accurate collection, others didn't collect it at all. And so this was really a good opportunity for us to just identify what type of intervention we wanted to do and then do those PDSA cycles. So we did 3 of those. 2 of them were around patient reported race and ethnicity. And then our final one, which is on the next slide, is around sexual orientation and gender identity. This was an amazing experience to be part of the Health Equity Collaborative. I think all in all, there were about 50 hospitals that participated, all building health equity simultaneously and all at once. And it was amazing. They had these quarterly meetups where you got to report out on just how your sprint went. And then Wisha did a good job of connecting hospitals to one another if there were some similar efforts that they were doing. So I found that experience to be really invaluable. And then we also had an opportunity as a hospital to present our efforts on race and ethnicity collection because it was such a huge improvement by just standardizing collection. So I just wanted to share this because it was a big foundation for the first year of the program, in which we even conducted a gap analysis to even find out where were we in these 3 particular domains. So we did do a pilot to collect sexual orientation and gender identity in actually a few of our clinics. So this was specifically in our cancer prevention and genetics clinics. And we did this pilot for about 3 months. And really what we wanted to see is we had a high unknown rate in the patient's medical record for patients coming in. And if we just collected this when they were scheduling their appointments, could we reduce that unknown rate? And lo and behold, by just asking patients, we did. So we went from, I think, at 51.5%, that was early days in October, down to about a 27.5% in mid-December. So that was some great improvement. And this was very low stakes, very minimal scripting with just asking patients, would you like us to include, how you identify? We did, of course, work with our patient education team to ensure that we had scripting. We did vet the scripting through our our free, those are our Fred Hutch employees for equity. So they went ahead and just vetted the scripting for us to ensure that it was appropriate and that we could answer any questions that some of our patients may have. And it was actually a pretty positive experience for our staff because some of them who were also part of the queer community were just thrilled we were even asking questions in order for patients to identify. All right, so moving on to screening for social determinants of health. And I know I'm moving through this really quickly, but I just want to give you all the information before we open this up to a discussion. Part of our goals as a hospital, that's for our quality assurance performance improvement plan, or our QAPI plan. Essentially, every hospital has one. Just kind of focus on what quality improvement your hospital is going to do for the upcoming year. We had a goal to just pilot SDOH screening in one area. So we successfully did that. We formed a work group. We did a gap assessment. We crosswalked the social determinants of health domains of what CMS had recommended, what we already had in our medical record system in Epic. And then we launched a pilot starting this January, and that ended in May. And so that pilot was really successful. Again, Sonali was actually part of that work group as well. And because of the success of the pilot, we will now be implementing screening for SDOH for all of our new patients coming to any of our sites who will be on active treatment starting in September. So this is huge. This is a huge deal for us. You know, there were some questions that were even brought up earlier today by one of our providers who said, yikes, you're going to be screening, you know, like literally thousands of patients. Do we have the resources we need to refer patients to those resources if they screen positively for any of these domains? And that's a completely valid question. And so it's kind of the chicken or the egg, unfortunately. Without data to really support our resource requests, it's really theoretical. And our leaders are not leaning on theory or doing the right thing, even if we think it's the right thing. It is, hey, we screened, you know, patients for about a year. X percentage is screening positively in these domains. This is what's going to take in order to meet the needs for those patients. So that is the route that we're going to take. So I'm thrilled and excited that we'll be screening all of our patients for SDOH across all of our clinics instead of just one. And there's just more to come. We're excited, and we're really ready to make a resource request, because we know that what we have for patient navigation, what we have for social work is not going to be equipped sustainably to meet the needs of our patients who will be screening positively. The domains that we screen for on the left-hand side, so that's housing instability, food insecurity, transportation issues, utility problems, and interpersonal violence. The way that we had our pilot is that when patients went ahead and met specific criteria, they went ahead and completed a survey. Their scores would be sent to the and if they screened positively, sent to the appropriate work queue in Epic that would ping that particular resource. So it would be social work, or it would be patient navigation. We worked with an MD leader and a champion to host that pilot in his clinic. That was huge and instrumental to have his buy-in. And then, of course, we worked with several different partners to get this pilot up and running. I do have some data here. I'm not going to dive into it, but it was really important for us to ensure that we were tracking the patients being surveyed, how often we did this on a weekly basis. And of course, for any patients that met the threshold for referral, we really wanted to track that too. All right. So one of the quality improvement projects that I'm personally really passionate about is addressing pain-related ED visits. We have had higher rates of ED utilization from Legacy Seattle Cancer Care, now Fred Hutch Cancer Center, compared to other comprehensive cancer centers. And this is also a publicly reported measure. So we are comparing ourselves to other cancer centers nationally, and we still have higher rates of utilization comparably. So our analysis that we have found shows that pain management is a driver for a persistent disparity over time that's affecting our patients who identify as Black, African American, and Asian, comparing to patients who identify as white. So what we've done for the last couple of years, and this was part of the equity analyses that Sonali was a part of in 2021, that identified this statistically significant difference for this disparity. It's been a lot of discovery work and really doing a root cause analysis to really figure out what is driving our patients to the ED. Once we unraveled and found out that it was pain-related ED visits, then that's when we started doing deep dives and drill downs into our patient chart reviews. For the patients who had gone to the ED for pain, really just trying to come up with some themes and reasons why they were going there, what was missing in the outpatient setting that we could capitalize on. We also spoke to about 20 patients for patient focus groups representing diverse service lines, just different diversity in terms of their identity and then geographic location, plus the clinics that they were actually treated at, because we have several community clinics in addition to our Seattle clinic. And then we also wanted to talk to our providers and then our clinic managers on their perspectives regarding what we're calling the pain problem at Legacy Seattle Cancer Care and Fred Hutch Cancer Center now. So what came of that discovery work was forming a project steering committee last year, this should say 2022, not 2023, to really hone in on some quality improvement efforts around this disparity. I came up with a fishbone diagram and pretty much said, here are the different root causes. What do we want to prioritize? And we really wanted to focus on internal processes and changes without burdening patients. So we focused on doing roadshows about this disparity, making sure that providers and staff were aware that we even had an ED overutilization problem and that a key driver of that was pain-related ED visits. We found that our patient pain management education was inconsistent. Literacy levels were a little all over the place, and then the distribution of those pain management materials were not consistent across service lines. They were translated into various languages, which was great, but the access to those actual materials just weren't clear. Some of them were online, some of them were printed, some of them were being handed, some of them were being sent on my chart. There was just no consistency in the distribution. So that got cleaned up with a subcommittee focused on that. We did also identify an area between our pain clinic and our referring providers where there was often a gap or a drop of patients who were going there for consultations. So once a patient had a consult in pain clinic and got really great recommendations for what to do next, some patients were just kind of left hanging with, okay, now who's managing my pain? The pain clinic saying it's not us, and the referring provider saying, I sent you to the pain clinic. So then we did some process improvement there to ensure that there was communication back from the pain clinic to the referring provider that was in the medical record. So then the patient could also see what those recommendations are and then know who will be owning their pain management going forward. Lastly, we went ahead and streamlined some pain-related policies. We had about 3 of them that all said 3 different things. So I think like each one said something like pain must be screened at every appointment for each patient. Another one said pain is highly recommended to be screened at for every appointment, so on and so forth. So literally got the owners of those policies together and said, what do the NCCN requirements actually say that we do? Let's make sure that they're actually standardized and consistent across all 3 policies. That was actually a pretty easy lift and pretty supported by those policy owners. So where do we go from here? Because that work just finished in the last couple of months since I've been back from maternity leave. We want to continue doing more discovery work. And I know that there's a point where you're just going to keep digging and digging, but we have to take some action. And I totally agree. One of the areas that I've always been passionate about, and Sonali, I think you too as well, is really looking at the experiences of our sickle cell patient population. That's something that we have avoided. It's like the elephant in the room. And it's something that I really just want us to start looking at. So I recently just put in a data request to look at our last fiscal year ED visits again, and then do a drill down on the patients who are there with a sickle cell diagnosis. And then really looking at that outpatient pain management experience, because there is a disparity even when we've carved out benign heme patients, including sickle cell. So adding those patients back in, I just want to understand what are we doing, if anything. We are introducing a red cell exchange service starting in January, with training starting in October. So I think that'll help. But I do still want to do more of a drill down to figure out what is going on with sickle cell. And I plan to provide a proposal for fiscal year 25 to actually run a pilot and to ask for some resources, whether it be nurses or having faculty time. because I was actually out on maternity leave, I was not able to put in a resource request for us to run a pilot to do resources, but that's going to be my intention for next year. So that could be around sickle cell, that could be around a different service, but it's something that I'll be spending the next year looking into. Lastly, I wanted to talk about a new venture, the newly formed Health Equity Steering Committee at the Fred Hutch. This is brand new. Our first meeting happened on June 30th. And why this is a big deal is health equity activities and initiatives are happening across our center. We have an office of community outreach and engagement. They're doing stuff. We have our high core. They do values-based outcomes research. They're doing stuff. We have independent investigators doing studies on health equity. There's no centralized place that has a pulse on everything for health equity across our center. This was a gap I actually identified when we merged together because I was doing stuff and our research staff had no idea what I was doing and vice versa. So after doing a little bit of exploration to see, is there a central body doing this? I decided we're going to just create a group and got some executive leadership support to form the steering committee. One of the best things about the steering committee is that it's being co-chaired by one of our faculty members, Dr. Hannah Linden, who's a breast oncologist. And we want to make sure that not only are we providing oversight and monitoring activities, are the activities that we're doing effective in actually addressing disparities and then being accountable when those efforts don't succeed. So that's something that's completely brand new and something that I'm really happy for. We do have some executive sponsorship, which is really great. And the big ask that we're hoping to do in August is to get Dr. Lynch, who's our president, to be on board for this Health Equity Steering Committee as well. As soon as he says, green light, this is a priority, things start to happen a little bit faster. So that is going to be the ask that we're going to have later this summer. So I just have this really quick section here. It actually kind of feels like it's not appropriate, Sonali, just given everyone's passion and interest in health equity here. But this is something that I like to share with some of the staff members at Fred Hutch. These are just small reminders. Maybe this is a good exercise internally for you, but just, what drives you to this work and your commitment for health equity, and then use that as your inspiration and to take action. Clearly, the folks on the call are doing that already. And these are kind of the small things that I'd just like to mention to our staff, that whatever you do, nothing is too small. So that shouldn't paralyze you from doing nothing. A big part of this is just checking our biases. I obviously have them too. And that's really just, the first step. And then leveraging your position. If you're working in healthcare, what can you actually do to make a difference in the health equity space? Sometimes that can be challenging the status quo, which I love to do all the time, and not taking this is the way we've always done it as the final thing, the final say. And then what I call the 4 Ps and reviewing that and changing them. So what are those policies, procedures, processes, and practices? Are they equitable? Do they actually reflect every single person that we're serving? Do we have patients' voices there? Who's actually making decisions regarding the 4 Ps? And then because I'm a big advocate for always having patients and caregivers' voices, are we including them in the conversation? So for our Health Equity Steering Committee, for example, we have one, and I want a second patient advisor to be present. And I really also want to get a community member involved in the Health Equity Steering Committee just to ensure that their perspectives and their voices are at the table. It's just important to ensure that they're there and to really check us as well, to keep us accountable to the work that we're doing. All right, that was a lot of information, and I know that I speak really quickly. I wanted to take this time to say thank you to all of you so much for giving me this space to chat about the program, and I'm happy to answer any questions that you may have.
Thank you, Tiffany.
Don't need to clap.
Yes, I think people are saying through their claps what I'm feeling. Thank you for that masterful presentation. You walked us through the whole journey, including that last section was also very, very important. And thank you also for your permission to record this, because once we put this on YouTube, even more people will have access to the material you have presented. Thank you so very much. I'm going to stop the recording now and we'll continue our conversation.